Aloha. My name is Grace Lowe, and I'm with PTC. Welcome to our last session for the day, Telehealth 2.0, the next phase of new realities in healthcare, a US, EU, and Asia perspective. Without further ado, I'd like to turn it over to our moderator, Atsushi Yamanaka, with the JICA Rwanda ICT Innovation Ecosystem Strengthening Project. Atsushi?
This is a session on Telehealth 2.0, the next phase of new reality in healthcare. So we have actually distinct panelists here, but as we all know that we are in the midst of pandemic. We were supposed to be there in the sunny Hawaii. Unfortunately, we cannot be there due to the pandemics. And as we know, there's actually a lot of things happening because of pandemic, and we are facing the new reality. One of them is that we have to do this on teleconferencing during the Zoom. My name is Atsushi Yamanaka. I'm a professor at the Kobe Institute of Computing Graduate School, which is a premier ICT for development school in Kobe in Japan. But I also actually do a lot of consultancies, including JICA's work in Africa, and some of the areas is actually in the telehealth area. So I'm really excited to actually have this session. I'm going to be the facilitator of the session, where we're going to hear the distinct panelists, their views, and their actually context, and their also opinions about what is going to happen in terms of telehealth, and how can we actually have telehealth to mitigate some of the challenges that we face during the pandemic and beyond. So we have here Dr. Christina Higa. She's a co-director of Pacific Basin Telehealth Resource Center, University of Hawaii at Manoa College of Social Science Research Institute. Dr. Higa. And then we have Dr. Anthony Meder, Professor of Digital Health System, College of Nursing and Health Science, Flinders University, Australia. Thank you, Dr. Anthony. And Dr. Mehdi Hassan, Senior Research Fellow of Digital Healthcare Program, Integrated Development Foundations, Bangladesh. Dr. Mehdi, can you raise your hand? So, thank you. So we're going to actually ask each panelist to introduce themselves, what they do, their work, and also give us some of the context so that we can move into the panel discussions. So could I start with Christina?
Sure, thank you. So I'm going to go ahead and launch my slides here. And thank you for the introduction. Just want to check you can hear me okay? Okay, great, thank you. So today I would like to provide you some information about the telehealth resource centers in the United States and how COVID-19 has impacted telehealth, and then maybe some discussion points for trends and directions. So first, our resource centers, there are 14 of us, and we are funded by the US federal government through the Office for the Advancement of Telehealth. We have 2 national centers, one that's focused on policy and the other on technology, and 12 regional centers that covers all the states and territories. Mine is the Pacific Basin Telehealth Resource Center that covers the state of Hawaii and the Pacific Islands. And I just wanted to say that in the last 9 months of the pandemic, our technical assistance had requests has increased significantly over the last 9 months, with maybe double, triple, maybe even quadrupling the number of requests that we've had to really help providers to quickly transition their healthcare to telehealth in response to the pandemic. So we've seen a major surge, and I wanted to talk a little bit about COVID and the situation that it is today to give some context. So I checked the World Health Organization dashboard this morning, and today this recording is December 21st, 2020. Globally, there are 35 million confirmed COVID cases with 1.6 million deaths. And in the US, unfortunately, we account for 1/5 of those deaths. We are the highest country with recorded cases of COVID, 17 million and 313 deaths. Just in comparison, yesterday I checked, and yesterday's count for Japan was 2,800 deaths. In the US, we have about that much or more deaths per day, so it's quite severe. In addition to the COVID virus, the Center for Disease Control said that 4 in 10 US adults are reportedly avoiding their medical care because of concerns of going into the clinic and getting affected. So this is going to be causing some compounding health issues. And also, sadly, the people who are mostly avoiding the care they need are people with disabilities or people with 2 or more comorbidities. And telehealth does provide an option for these people to continue to receive their care that they need and to be safe. So it's been promoted in that way. So just wanted to move on to talk about the surge. For us in the United States, Medicare is the federal program that supports the elderly and people with disabilities. And you can take a look at this. In the first month and a half of the pandemic, there was a 11,000% increase in the surge of telehealth. So that number is kind of just mind-boggling. I just also wanted to point out that Medicare serves our seniors, and according to many studies, seniors are embracing the use of telehealth. But I really like to dig deeper down to find out what made the experience favorable or not. Also Medicare, 60% providers have been providing telephone or video appointments during this pandemic in comparison to only 22 prior. We don't have the same data for Medicaid, which is a state-run program for covering people who of low income. We also don't have data across the states for private or self-insured. But what I can offer you is our data in Hawaii. Prior to the pandemic, we had only 20% adoption of telehealth. But if you take a look at this list, this represents our large health systems, our Native Hawaiian health systems, and our small systems providing service to our most vulnerable population. And across the full spectrum of healthcare service providers, they are using telehealth. I think this is a reflection across most of the states. So some of the driving factors of the surge of telehealth, public health measures. The state issued stay-at-home orders, the social distancing, avoiding unnecessary exposure. Early on in the pandemic, we had PPE inventory concerns. So telehealth is just natural to helping facilitate all of that. And it was a widely promoted alternative to healthcare, in-person healthcare. Very importantly, in parallel to that, the US federal government made swooping emergency policy waivers to advance telehealth during this period. And some of these changes include improved provider payment for reimbursement, allowing providers to serve patients outside of their state, allowing for more eligible providers and type of providers to get reimbursement, reducing or waive patient cost shares, allowing federally qualified health centers and rural health centers the ability to serve as originating sites for telehealth services. Patient location was really important because it was very prohibitive prior to the pandemic, where patients needed to be in a healthcare setting or in a rural area. But with the emergency policies, a patient can be at home. It can be, he or she can be in an urban or rural area. Also, we have had relaxed HIPAA, Health Insurance Portability Accountability Act rules. So for example, people are using FaceTime on their phones for telehealth, which would normally not be a HIPAA compliant technology. CMS, the Center for Medicare and Medicaid Services, also added 135 telehealth services for eligible for reimbursement. That's more than double of what was allowable before the pandemic. Here are some of those services, and I just wanted to point out the therapies: physical therapy, occupational therapy, speech therapy. Those were added to the list only later in the pandemic. Wasn't approved before, added to the list now. We're not sure if those will carry over once the pandemic health emergency is ended. We can't guarantee that all of these will continue to be reimbursed. So with the few minutes that I have left, I wanted to just reflect on this largest telehealth experiment in the US, perhaps in the world. What just happened, and think about it. So in terms of utilization, I think I presented to you some information about the rapid and wide-scale telehealth deployment because of the dire need, the enabling policy that went along with it, the public health emergency motivations. And I also just wanted to point out that as communities and health systems started opening up, the telehealth numbers did plateau and maybe dip a little, but they're nowhere near the low pre-pandemic numbers of utilization. So that's sort of an indication of where the future is going, that it's not going to go back to the low 20% adoption, as I mentioned at the start. Patient and provider benefits. This one is tricky because there's a lot of patients or providers who never thought they would ever want to use telehealth, and now they are, and they find it convenient and they find it efficient. However, there's caveats to that. There's always if it's working well, if the technology is working well, if my patient knows how to log on. So there's a lot more work to be done in supporting both the patient and provider experience. In terms of outcomes, we need more information to collect to understand cost and clinical outcomes. But what I can say is we're seeing across the board that there has been a reduction of patient no-shows using telehealth. Because if you call your patient's smartphone and they're 1 minute late, you can easily have them connect up for your appointment. Maybe if they're driving, pull over to the side, find a quiet room. But in the past, if they were somewhere 20 minutes away, you had to reschedule. So I'm anticipating a lot of cost savings on that point, and potentially improve quality of care, quality of outcomes for patients because of more touch points with the patients. And also protocol, workflow systems, technical systems. A lot of health systems were planning all the bells and whistles in their telehealth system. And what we're finding is keep it simple is the best practice there. And this is my last slide. Just wanted to reflect on the challenges and future solutions needed. So as I mentioned in the beginning, only within a few months, people just threw together telehealth services. Now we see them, they really threw aside their systematic long-term planning, and now we're seeing them trying to refine and optimize those protocols. Since this is for PTC and there is a huge technology audience out there, I'm throwing this out for our audience, we really need a better interface for our telehealth platforms. Right now, we're using so many different systems. And what I mean by the telehealth platforms, I mean Zoom, Doxy.me, Doximity, all those different things, and people invested in it. Well, patients are having to learn 5 different systems. I heard in a presentation the other week, Alaska clinic had 11 different systems to use. So we need something that will allow us to communicate seamlessly together. And also the new focus is our challenges direct to consumer. We never, even as resource centers, had to pay attention so much to the patient and families and in their specific home in their own settings. And with my final seconds, I hope we talk more about this in the discussion point, a big spotlight on digital equity solutions. It's not just infrastructure, not just the satellite or fiber, but it's access, the affordability of the broadband, the affordability of the equipment, and digital literacy, the know-how to use the technology for improved quality care of providing it or receiving it. Mahalo and thank you. I think you're muted, Yamanaka Sensei.
Sorry about that. We always do that when doing the Zoom. Well, thank you so much, actually, Christina, for giving actually a good context of what's going on in the United States in terms of telehealth. As you have mentioned, this is really, the States is by far the largest, actually, the patients within of the COVID-19 and largest deaths, unfortunately, as well. So it is really something that telehealth is really trying to mitigate the situations, and we really need to actually have that. And it was also very interesting to hear about the rights-based approach, especially in terms of digital equity. And that I really want to go into the final discussions. Thank you. Anthony, can I actually pass the floor to you?
Yes, thank you, and hello, everyone. My role is the director of a university e-health and telehealth research centre in Adelaide in Australia, but my background is very much in health informatics, and I've worked in various other centres and government agencies. So my perspective is really a personal one, but with some national engagement. So first, I'd like to just set the scene for the Australian health system, because the nature of every country's health system does vary. And although we have a relatively high standard of healthcare for the Western world in Australia, the way we implement and deliver it is a little bit different from many other countries. So the Australian health system is very strongly biased towards government funding and government reimbursement. It's not a fully national health type of system as in the UK. It's more segmented, and a lot of the control is given to individual states, a little bit like the Canadian system. So the central government provides funding directly to states, but each state must set up its own health delivery environment. And that generally covers about 2/3 of the health services for any given state, the remaining third being privately delivered by a very large number of smaller organizations, such as religiously based entities, charitable entities, and so on. Like most Western countries, our health service relies on national budgets. So about 10% of our budget is currently spent on health, and we've had the usual quite scary projections that it will double in the next 10 years and so on. And of course, that won't happen. New methods will have to be found to contain budget blowout. But the national system covers acute care through the hospitals, primary care through general practitioners, and a variety of allied health and aged and disability care services that are controlled through clinical colleges. The important thing about our system is that the government reimbursements are only made according to scheduled activities. So there's a list of services, there's a list of medications, and so on. And these are reimbursed at the government rate, but anything else is outside of that. So for example, seeing a specialist has to be paid for by the patient. The idea behind this is that people should be able to get minimum mandatory type medical services, but not the perhaps voluntary or additional ones. So the second component to our system that's of interest here is that we have a nationally coordinated My Health record system, and all Australians are automatically recorded online unless they opt out. And the uptake rate is quite high for that. It's over 90%. So this means that the government has a channel for both recording and communicating about health in a quite efficient way. So on your online record, you would be able to see any encounters with the health system, any prescriptions, any test results, immunizations, and so on. So in a sense, that has prepared us for a much more e-health oriented environment. But unfortunately, the rollout of e-health services has been somewhat slow because of the perhaps suspicion and concern that going in that direction too fast would be hard to retract from. And so for that reason, telehealth has been a relatively minor aspect of care in the past. It's been really at the preference of the clinician or for the state-oriented health hospital systems. It's been dependent on whatever environment they set up. So some states, for example, Queensland, have a highly developed, highly integrated telehealth system across all their hospitals, whereas others, for example, in Victoria, have got hospital by hospital services. The other difficulty has been that the government has been quite resistant to telehealth as a reimbursable service because they're very afraid of blowout and suddenly everything transitioning to telehealth. So that was the scene before COVID started. As soon as we got to grips with COVID, a number of service impacts happened very rapidly. The first and most noticeable of these was that the primary care system, general practitioners or family physicians, as you might call them, transitioned very rapidly to telehealth, encouraged by the government allowing reimbursement on all telehealth consultations. So we moved from just specified consultations, such as rural and remote or indigenous peoples, to any patient who wished to receive telehealth being able to do that, and the government would reimburse. So suddenly we had probably a 10-fold increase in telehealth consultations in the primary sector, and now more than 2/3 of all consultations are being delivered that way, whether they're actually needed or not. So the convenience factor has really dominated the market shift. The interesting fact about these is that more than 90% are audio only. They're telephone delivered. The catching on of video has been very slow, and perhaps this has overcome one of the problems Christina highlighted about multiple video service provision, because with audio you've only got kind of the standard telephone system to deal with. Certainly the older clients, and particularly those who are in aged care facilities and managed living, have been very responsive to telehealth, and they've been much more communicative than they would have. The egalitarian mode of communication that's provided by telehealth means that the patient isn't quite as scared of the doctor as face-to-face. Two major services transitioned to telehealth delivery: pathology, where now tests and results are being delivered electronically, and prescribing, where scripts are being sent direct to pharmacies of one's choice, were both set up very rapidly after only a month or so of negotiation with the various provider networks. Another telehealth innovation has been the starting of home monitoring. So when patients are told to self-isolate or when they're sent home to recover, some hospitals are providing quite detailed wearable-based home monitoring systems. Again, there's no national standard, it's hospital by hospital. So a large reduction in patients with chronic disease coming for their regular meetings was also noticed. It's as if this has become less important than COVID, and people are letting slip their, say, 3 monthly diabetes assessments. The last area that's been strongly impacted by COVID is mental health. There were a lot of services which were providing online telehealth-based support for people or distress and inquiry lines, and those services have been reduced somewhat because they had to pivot to other areas. And so the ongoing support of mental health in this situation is questioned. So to make some concluding comments about the impact and the policy and trend of this difference that we've been seeing, it's very encouraging that the rapid introduction of these new funded services was achieved so easily with minimum bureaucracy, minimum overheads. The government has said that they intend to continue with telehealth indefinitely, having found that this was a very positive experience. It's yet to be seen whether they squeeze, perhaps they reduce the reimbursement rate for telehealth consults. It's also interesting to see how much central coordination, for example, of standardization will occur. Interestingly, clinicians who were quite nervous about telehealth have adapted very rapidly and generally report very positive experiences and patient outcomes. And there have been no publicly aired complaints of inadequate consultation or inadequate ability to serve the client needs, as was claimed to be one of the blockers earlier. The Minister of Health recently made a quite outrageous statement. He said, "Our 10-year strategy for telehealth has been achieved in 10 days. And this was largely due to government relaxation, not due to the lack of readiness of the health arena. So we expect, that this will continue, that there will be more home care, more direct patient monitoring, more support services, as well as the consults, which will be delivered by telehealth. And interestingly, a lot of these are becoming more farmed out to private industry, more delivered by individual provider organizations and outside of the government purview. An example of this is palliative care, which is unfunded, but which is now delivered by a number of service organizations. So thank you. I hope I've given you enough of an overview to understand that Australia has a vibrant telehealth environment, mostly due to COVID.
So thank you so much, Anthony. Actually, it's Actually, it's very interesting to hear about regulation, especially. I think this was the same with Christina's comment about the government is all of a sudden saying, no, we have to do telehealth. So they actually relaxed a lot of regulations. So because of that, as you said, like 10 years of telehealth can, have been done in 10 days. It's, I think, in a way, it's a positive thing in very, very negative situations. I think this is something that is very interesting. Another thing I found it particularly interesting is about teleconsultations done in audio only, because the introduction is done by Mehdi. He's actually going to give us from the developmental path perspective from the developing countries, and I also coming from there, so where the infrastructure even more restricted. Even at the remotest areas of Australia, perhaps. So it is really comforting to actually hear that this kind of simple methodologies also is still applicable and very useful in that context. Of course, we like to provide more videos and additional services. Another thing which was very interesting was actually there was actually the overall sort of e-health management systems already built in Australia. I think that is really something which other countries are really covet for. They don't have that. So that is the reason why it's very difficult actually to advocate the health concerns as well as to manage the cost-wise as well. I think that we should reduce a lot of the cost. And it was also interesting to hear about government's attitude has been changed, and then but still they actually have a resistance in terms of reimbursement rate. I tend to think that going to telehealth would actually reduce a lot of costs. So it is actually, maybe we can go back to that particular point in the panel discussions. So can I actually go to Mehdi, and then he's going to talk about from the Bangladesh perspective, from the developing countries perspective on telehealth. Can I pass it to you, Mehdi?
Thank you so much, Professor Yamanaka. Let me share my slide. Everybody can see the slides? Okay, perfect. Let me put it here. It's loud and clear?
I actually have to ask you to zip it through, as we don't have a lot of time.
Okay. Yeah. Okay, good afternoon, everyone. Thank you so much for having me in this session as one of the panelists. This is my third time in a row to join PTC, and good to see my fellow colleague, Dr. Christina and others. Today, my discussion will be, were we able to secure an accessible, affordable, and sustainable telehealth service for unreached community in Bangladesh? United Nations identified 7 goals as SDG, and in order to achieve the goal number 3, good health and well-being, a couple of major tasks need to ensure to achieve the goal that has been identified by World Economic Forum. I'll point out the access to care and healthcare delivery system. Let me share with you some of the statistics and the context of the healthcare landscape in Bangladesh. The country's total population is more than 160 million. And if we look at the doctor and patient ratio, then we can see 0.58 doctor for 1,000 people, and 4 hospital beds for 10,000 populations, and 5 nurses for 5,000 population. The number is not actually far from here with other neighbor countries in Asia. I will talk about later about this. We know that technology can contributing significantly to bridging this gap in developing countries. Globally, more than 53 billion individuals are using internet. Likewise, in Bangladesh, nearly 100 million people using internet. 124.7 million mobile subscriber, and more than 97% network coverage around the country. But still, Health tech is the third preferred investment sector. As you can see, the first one is ride sharing and logistics. Second one is fintech, and third one is health tech. Though telehealth is not a new initiative in Bangladesh, however, in terms of access to care and healthcare delivery system, it was hard to measure from the KPI, accessible, affordable, or sustainable point of view. From last couple of years, more than 10 telehealth services are rolling out at this moment in the market. But the major concern is how digital literacy is the barrier to take the services. This figure actually on the right-hand side shows that the 37% South Asian has top barriers to use mobile internet. In the left side, that table shows some of the available features in the current telehealth services. Since 1985, our organization, Integrated Development Foundation, has ensured healthcare services to more than 400,000 unreached community people in Bangladesh, including Rohingya refugee camp. And recently, we have introduced telehealth services in 15 different locations and have served more than 400 patients. I think I'll talk about in detail later on in the panel discussion section. Yeah, that's all in my presentation. Thank you so much, everyone.
Thank you, Behidi, about that, actually. Since I'm actually coming from the developmental perspective, it is really, telehealth is something not actually new for many of the developing countries because we don't have enough doctors. So we were actually forced to use the telemedicine, telehealth, but at the same time, we did not expect this much sort of, the increasing demand, and the infrastructure is still very weak. And digital literacies, as I think we're going to talk about digital literacies, is much weaker in developing countries. So in that respect, there's a lot of still challenges to overcome. So thank you very much, all the panelists. That was very good context as we can move into the panel discussion right now. I've been doing actually ICT for development for about 25 years, and I've seen a number of telehealth initiatives. And in many cases, I found it very difficult to change the mentality of both the doctors as well as the patients about telehealth. Patients say, I have to see my doctor. The doctors as well, I cannot really do the consultancies online. This was still the case, for example, in Japan during the COVID-19. They are resisting. They're saying, this is only exceptional cases to do the telehealth during the pandemic. But after pandemic, we'll go back to the normal system or the regular system. But I think this is really something, people start changing this. What do you think, Anthony, what do you think? Do you really think this is happening you said this is happening in Australia, 90% of patients are satisfied with this already. Do you think this trend is going to continue beyond the pandemic?
From an Australian perspective, yes, I think we've transitioned, totally into an environment where telehealth will be normal for everybody. I think the two problems that have occurred in the past that have been overcome by this are that firstly, telehealth was seen as something for rural and remote health delivery. And it wasn't really thought of as a city or a close range effect. Now that's, of course, changed completely because of the wish to avoid the physical proximity and physical contact that's implied. So I think people will just find that it's convenient and, as we said, a little bit less costly and probably allows for easier scheduling, as Christina said, all those benefits which suddenly were not part of the equation because they weren't that applicable in the rural setting, for us now become kind of dominant. The other thing that I think has been significantly different is that just over the last 5 to 10 years, the demographic in healthcare providers has changed substantially as the government has provided more places for education of doctors, nurses, allied health practitioners, and so on, the number of young professionals has grown considerably. And of course, the young doctors have no problem using telehealth. It's just part of their telecommunications lifestyle. And so that has made a lot more positive pressure for the transition. And of course, it will stick because those people have grown up with those technologies and, will just continue to use them because it's normal.
I think this is also attributed to the evangelists like you, who has been really advocating for telehealth. So finally, I think they're catching up with what you were talking about. So I think it's quite exciting in this respect. So Christina, what do you think about this, changing of mentality, both the patients and then also the healthcare providers?
Yes, actually for a resource center that suffered years and years of trying to convince providers that it was a good thing to do, we were eking 2% adoption, 5%, finally 20 was pretty good right before the pandemic. And now, the numbers are across the country, it's like over 150% of, like double, almost double. So, it really has a lot to do, well, let me see. Last night I was in a class and a Japanese student in Japan asked me, his question was, how could this happen overnight, all this change, when US had such severe COVID situation, right? And then I had to answer in the way my father taught me, that the answer is in your question. It's because of the severity and the need that the normal barriers and the bureaucracy and all of that was broken down. So my question really would be, how is this going to carry on into the future? And I think we touched on some things that has to happen if it will. One would be the payment structure, the policies that also allowed certain kinds of providers and certain kinds of services to get reimbursed. We are still waiting for a lot of those decisions to be made here in the United States. But I think, like Professor Meter has mentioned, it's already out there. People know the convenience. People understand that it can work. And so we're going to have to figure out how to make it work moving forward. And on the last point of the Professor Meter, the young professionals, that's actually a concern of a lot of my healthcare colleagues, that they're going to only want to teach online, not teach, but provide health services online, and that we'll have a lack of people to see the patients in person. And of course, we're going to have to move forward in a hybrid situation, right?
Actually, that's a good point, because when I first actually tried to do the telehealth project back in Mongolia 20-something years ago, almost 20 years ago, the doctor was saying, we actually need doctors. Telehealth cannot actually replace, doctors. So, doctor is there. It's just how can you actually empower doctors to do that? So I'm really, happy to hear that comforting words from Christina. So maybe, do you think it's gonna? I mean, since developing countries, we have forced to do this anyway. But COVID-19, are they changing this in quite drastic way? Are they adapting much more faster on this? Are they encountering new challenges? What do you think?
I mean, a couple of things that I would like to mention here. In Bangladesh right now, there are 5-6 telecom operators. And from the very beginning, from the infrastructure point of view, we have some very strength point. I mean, in terms of we have a SIM card is less than $1. Our feature phone is really very much cheap. Anybody can afford that. I mean, we have more than 97% network coverage around the country. So from the infrastructure point of view, we have an advantage, which is, I think, one of the major parameters to set up the telehealth, the services. But on the other hand, the doctors are really, when I talk to the doctors, before March, they really feel they had a strong feeling that without touching the patient, it's really tough to, the diagnosis, any kind of disease or something like that. But after March, when they stay in the call center, they feel that it's okay. I mean, for most of the diseases, we can do that. I mean, and on the other hand, from the user or consumer perspective, they think that whatever the service, I mean, we don't care who actually giving the service right now, either in the telco and the other private organization. We need to see the doctor. I mean, we want to talk just one-to-one. I mean, the platform can be anything. So as we have already the setup, and we have the services, couple of services is there, but still shortage. So users are pretty much comfortable at this moment. But yes, this is very true. As I mentioned, that digital literacy is one of the major constraint here, barrier. And when I see from the low resource settings from the unreached community, it's really different. Because they need actually someone who will be in the middle of their side and from the doctor. Someone should be there who can connect between these two dots. So we need more healthcare worker or healthcare assistant who have that also knowledge. So if we can ensure that, people will be comfortable.
Good. Thank you so much. Yes, I think digital literacy, but you also mentioned a very interesting point that telecom provider is now providing the healthcare services. And I think Anthony also mentioned there's a lot of private sector entities trying to actually get involved in it. And I actually have a question in this because, healthcare is one of the most regulated industries. And yes, it was good that we actually had less regulations so that we could do the, healthcare innovations, especially in the telehealth areas. But how can we ensure the quality of services, if the private sectors come on board and they start providing these services? Do you have any, what should be the good regulations, especially moving forward with the telehealth in the future? I think this is a very big topic, but I would like to hear the expert's view on that. Maybe I can start with Anthony.
Yes, sure. It's very challenging because, of course, the market rules in a sense. If people are willing to pay for the service, even if it isn't comparable with the government-funded service, but is more convenient or is more to their liking, then you can't stop them from doing that. In Australia, the view's been taken that the clinical professions should exercise a lot of authority. They should, for example, provide guidelines that any of the registered practitioners in their field should follow. And so they hope that by using professional standards in that way, they can prevent maverick kind of behavior. But, there are companies. We have a company that basically provides a call service center for doctors very cheaply. And for 90% of clients, it's probably adequate because they're just seeking reassurance or reinforcement even of a self-diagnosed condition. On the other hand, in the percentage when it's really important, they're going to fall through the cracks in that system. The other thing the government has just started doing through our Australian Digital Health Agency, which is the government regulatory body, perhaps a little like the Office of National Coordinator in the US, they've started investigating whether to require enforcement of technical standards for telehealth in Australia. So the idea being that not allowing, for example, pre-recorded sessions with doctors, or not allowing sessions where the quality of the sound, the quality of the image is inadequate. And of course, it's very hard to enforce that, but at least if there were some guidelines and even perhaps regulatory standards, it would help.
Thank you, Anthony. That's really very interesting because I've seen some cases in developing countries where they actually have a call centers and a chatbot actually trying to diagnose some of them, to at least triage some of screening them, because as you mentioned, some of the patients, they want to have a reassurance. And I thought that was very interesting technologies and services, but at the same time, I was a bit worried about quality of service. So it is good to hear that Australia is embarking on the standardizations and also having a digital health agency. That's a very new. I think that a lot of countries should actually do that. Christina, can I move on to you? What do you think is really the balance on the regulations?
Sure. Maybe because America is probably the least of government provided services on the panel here, that we're used to private sector having a big role in providing healthcare, and it is regulated. But still, you know, and the other thing is, I'm not sure I should say this on a recorded session, but in the United States, if the government is providing your healthcare, sometimes people assume it's subpar. You know, it's like if you want the better services, you're going to go to a private sector space, someone who is not actually run by the government. So my concern would be having kind of, you know, for other countries that are introducing more private into the mix, are you creating, you know, the cream of the crop? Kind of all the people who can afford the services will get services from the private sector, and then if you have subpar, I don't know if that's the case or not, of government less expensive services, then are they left without choice? So that would be something just from the outside looking in. However, you know, in terms of enforcement of standards, that's something we are struggling right now, because telephone service is being reimbursed to a certain extent during this pandemic period, but probably will not be moving forward. So again, people who don't have access to the smartphones with video and all of that, how will they get their telehealth services? How doctors going to get reimbursed for providing them care? And so there's a lot of questions about quality, and not only that, about fraud, waste, and abuse. So how do we know for sure that this, you know, because they're talking about payment at parity, the telephone call, the same as video, the same as in person. And that's very difficult for us to monitor that. So systems, policies, all of that are being looked at right now to understand the way forward.
At the same time, you mentioned there's so many different interfaces to do that. That's also, I think, is one of the challenge I think you're facing that, I guess. Mayday, can I actually move on to the digital literacy parts? You know, because digital literacy at the client end, especially, I think is really something that we need to overcome everywhere. Anthony mentions about, you know, the young generations of doctors and nurses, they're used to and they're more comfortable using these technologies, but clients, you know, most of, I think, our patients are elders. So how can you actually change this digital literacy in terms of healthcare? You know, like changing the mentalities. It is okay to use the digital. What do you think from a developing countries' perspective?
Professor Yamanaka, let me tell you two important points, which actually the recommendation from the Broadband Commission policy. Mm-hmm. They have 26 recommendation, and 2 is really very much closer in this issue. First one is boost affordability and usability of broadband-enabled product and services. And second one is build human digital capacity and skills to help user. I mean, they are recommending these 2 issues. On the other hand, if we see the market in developing countries like Bangladesh, India, Indonesia, Pakistan, then we can see that from last 2012 to 2017, they actually decreased the average selling price of the smartphone. For example, in India, they decreased 45%, 2012 to 2017. Indonesia, they decreased 32%, and Pakistan, they decreased 14%. So, in one side, we see from the government or the private sector, the corporation, the companies, they are trying to disseminate. They are trying to help all sort of technical platform, technical devices, and those kind of things. On the other hand, this is very true. I mean, it doesn't mean that someone can call. It doesn't mean that someone can do the video call. That's really different. And in that case, while there were so many, the large number of people are using the feature phone, not the smartphone, which one has the video call ability. So that's really interesting. I mean, in Bangladesh point of view, I think the service provider who has the telehealth service at this moment, particularly who are focusing on the rural area, they should, at the initial point of view, they should appoint the healthcare worker or healthcare assistant in the middle of these two stakeholders, physician and patient, so that someone can has the training, 6 months or 4 months training. They can be paramedics who has the knowledge how to handle the software and how to handle the laptop or browsers to connect with the Skype or Zoom, something like that. We cannot expect that, okay, over the night, from tomorrow, everyone can do the like a Zoom or Skype. We can't do that. So we have to do it gradually. So for example, in our organization, IDF, we use the Skype. So Dr. Christina's point of view, make it simple. We thought that rather to make it a very high-tech, sophisticated platform, let's put it in a simple way. Just connect with the Zoom or Skype, and let's see what happens. So, IDF is also, from IDF, we are also trying to help one of the hospital called Qazi Halima Sattar Hospital. They are also thinking that how can we do from the very beginning the telehealth service with a simple, very user-friendly technology. So my recommendation will be, don't put so many high-tech platform at the very beginning to the rural user. Let's make it simple, and let's at the very beginning appoint some of the middleman, healthcare worker, so that they can do the basic things. Gradually, we can do that. Yeah, it will take time, but it can be. Yeah.
Thank you, Mehdi. Do you think this kind of approach will be useful? Also, like, in Australia, you have rural areas, a lot of rural areas where the infrastructure is challenging. And Christina, in Pacific Islands, it's really some places where they can really benefit from telehealth. And I think your organization covers some of the Micronesias and then some of these more challenging places as well. Do you think that kind of approach, sort of the rights-based approach for approaching the broadband or the internet, and also utilizing simple technologies, appropriate technologies, plus like using like information intermediaries like healthcare workers? Do you think that kind of approach would be useful even in the US, the Outer Islands, as well as in Australia? Maybe Christina, can you?
Okay. Yeah, I see the time. We have 3 minutes. I'll be
I know.
But absolutely, the answer is yes. And just to bring it to a very practical model in a small community in Hawaii here, we're working with our libraries where they will provide the infrastructure, the access to the broadband in the library for the telehealth consults. And then the literacy piece, we're working with the university and high school students and even the Department of Health, where they actually will be providing the training on how to use Zoom and Doc.me and all of that, navigating the patient through the health systems and through their practicum. So we're building it into like a workforce development. We don't have community health workers and health navigators right now in our communities, but we are working together to build the access side through the libraries. That's a trusted, safe place in the community with staff there. And then the digital literacy, education and training piece through the students. So that's just a very small example of what we're trying to do to bring those two really difficult things to overcome together in the community by working together as a village, really.
Thank you, Christina. Can I get your, what do you think of Anthony? That is also, I think, challenging in Australia.
Yes, very much so. And in fact, in Australia, the government recognised this and provided funding for intermediaries of various kinds. For example, with indigenous people, with people of different cultural and language backgrounds, with people at different stages of health progression through chronic disease and so on. The difficulty is that the funding was targeted specifically for rural and remote people, and to simply replicate that in the urban setting where 90% of the population lives in our country would be highly expensive and very difficult to manage logistically. I think what will more likely happen is those assistance or services providing assistance will be selectively provided if people have a need, and there may be some sort of threshold or entry point to access them. The other thing that's quite important in Australia is use of broadband and connectivity provided by a variety of mechanisms. We have a very extensive microwave network, which gives about 45 megabits per second service. We also have widespread satellite for the very remote areas, and pricing in satellite seems to have come down a little. You know, it used to be 100 times the cost of landline, but now I think it's much better. So perhaps that will also grow in the future, and we'll have a blended service.
Thank you so much. Actually, I think that is also quite exciting area. A lot of new technology, and I think PTC is really that kind of forum. We're actually seeing a lot of interesting innovations in the rural connectivity, especially broadband connectivity. So we wish actually this trend will continue. I think we have 5 minutes to go. So I want to actually give you the last words from each of you. Unfortunately, we thought this was 90-minute session, so we have to cut short a bit. But let's start actually with Mehdi. The last words of the session.
I think I joined in PTC from last year, so I can see from last year compared to last year's sessions and this year's session, there are a lot of discussion we need in terms of telehealth, remote healthcare systems setup and policy point of view. So that, I mean, we all know that this is not a new concept, but again, we have to, remind everyone that not only due to pandemic, but also after the pandemic, we need to make sure that telehealth or remote healthcare system can be more standardized for not only the rural community, but also the urban community. And we need to work together. Yeah, that's all. Thank you.
Thank you. Anthony?
Yes. So our politicians are very keen to talk about the new normal, by which they mean having to behave in a COVID-sensitive way for the conceivable future. And in the same sense, they're regarding the use of technology in the healthcare delivery as the new normal. I think that the impact of that has been that leadership is showing that that's the direction that will be reinforced and will be more widely adopted. And that's really helped with both clinician and patient adoption and attitudes of trust and attitudes of reliance on technology. And that was a sort of missing factor before. It was the great unknown. You know, will technology be a bad thing? But now it's been demonstrated it's a good thing. I think it's flipped that attitude, which is one of the big inhibitors in the past.
Thank you, Anthony. And then evangelists like you who have been really working hard on this, I think this is finally the time has come to say, okay, this actually works. Christina?
Yeah, I agree that, we know for certain that technology is going to develop, it's going to advance, it's going to be more mobile, all of that will happen. But it's all the policy, the perceived benefits are not, the behavior of change that have to embrace it moving forward. And for the United States, this is one very unique area, telehealth, and it has full bipartisan support in this administration. Telehealth has been supported even before the pandemic. So we were positioned in a well-positioned place for very quick and swift decisions to be made about reducing some of the policy restrictions and waivers. And so I think we were fortunate in that sense because we had been so divided in our country about many different issues. And even healthcare in general, and even wearing a mask, but not telehealth. So as Professor Meter has just said, that gives me a lot of hope that this can be something we can continue to work on to be unified, to advance. However, just as Dr. Hassan mentioned, I really, really think we have to be careful. We are going through a healthcare transformation right now, just like we did from when people stopped going to do house calls and started people coming into clinics. There's pros and cons. There's things that we left out that we don't have anymore, like connection to the families and the patient-centered care and all of that. There's an opportunity to bring that back. Great, but there's also an opportunity potentially to widen the disparities that already exist for people who don't have connectivity to the internet or can't afford the broadband plans and all of that. So just as hard as we're working towards advancing the technologies, it makes us have to work harder to close those gaps. Otherwise, we may be causing wider disparities that we unintentionally.
Great, thank you, Christina. I think time is up for us. Unfortunately, I would like to continue this discussion forever, but perhaps we can do this next year in person, hopefully in Hawaii. To see all the participants, thank you, mahalo nui loa. I hope that's right. And also to the participants to the conference, mahalo nui loa for watching this conference, this session, and aloha.
Thank you all for joining us today. We look forward to seeing you tomorrow for a fully packed day of sessions, as well as our opening reception sponsored by Puritan and women's reception sponsored by Paul Hastings. It's an early start, 4 a.m. Hawaii time and 9 a.m. Eastern time for the first subcable workshop sponsored by SubOptic. See you tomorrow.